Today's video is all about the diagnosis and treatment of DKA and nonketotic hyperosmolar hyperglycemia in real-world settings. In this video, we will discuss the following: how to quickly diagnose DKA or nonketotic hyperosmolar hyperglycemia, how to easily differentiate between them in clinical practice, how to not overlook the precipitating factors, DKA and nonketotic hyperosmolar hyperglycemia treatment, in which we will discuss the following: the goal of the treatment, the concepts of anion gap, effective plasma osmolality, and corrected versus measured sodium, the initial few hours in the ED, fluid resuscitation in the initial 4 hours, patient disposition, fluid therapy after the initial resuscitation, potassium and phosphorus hemostasis in DKA and nonketotic hyperosmolar hyperglycemia, the use of bicarb in DKA, insulin therapy, monitoring while on insulin therapy, and we'll finish with the transition from insulin drip to basal/bolus insulin therapy, when and how. This is going to be a dense video, so give me your full attention. This is the 9th video of the inpatient diabetes management course. A link to the full course is provided below. If you signed up for the PDF summary of our videos, it should be in your inbox 24 hours after it's released on the channel here. If you would like to sign up, please use the link provided below. Let's go. Presence of anion gap metabolic acidosis and ketonemia together is essential to diagnose DKA. The absence of one will rule out DKA. Hyperglycemia may or may not be present in DKA, as in normoglycemic or euglycemic DKA, where the serum glucose is normal or near normal. Normoglycemic or euglycemic DKA has been associated with the use of SGLT2 inhibitors, which makes sense, of course, as these agents promote glucose loss through the urine, minimizing plasma hyperglycemia. It may also happen in patients with poor oral intake or in those who receive treatment with insulin before arrival to the ED. And it may also happen in pregnant women. On the other hand, the presence of critical hyperglycemia and hyperosmolarity is essential to diagnose nonketotic hyperosmolar hyperglycemia. I've never seen a nonketotic hyperosmolar hyperglycemia patient with blood sugar less than 600. Ketonemia and acidosis may or may not be present. If present, they are mild and pH typically above 7.3. Abdominal pain, nausea, and vomiting are common presentations in DKA patients, but very unusual in nonketotic hyperosmolar hyperglycemia. Neurological manifestations are common and predominant in nonketotic hyperosmolar hyperglycemia, but may happen as well in DKA. I've never seen a nonketotic hyperosmolar hyperglycemia patient who was neurologically intact. Lethargy, confusion, obtundation, coma, stroke-like symptoms, and seizures all can happen. On the other hand, I've encountered a lot of DKA patients who are neurologically intact. The distinction between DKA and nonketotic hyperosmolar hyperglycemia may not matter much in the acute phase, as the treatment is the same, but it's not difficult to differentiate between them in clinical practice. The presence of critical hyperglycemia that is out of proportion to the amount of ketonemia and acidosis, along with the neurological symptoms, is strongly suggestive of nonketotic hyperosmolar hyperglycemia. But what do I mean by the hyperglycemia out of proportion to the amount of ketonemia and acidosis? The critical hyperglycemia seen in nonketotic hyperosmolar hyperglycemia would have caused more profound ketonemia and anion gap metabolic acidosis has it been a DKA. Also, the presence of abdominal pain or the absence of neurological signs or symptoms makes nonketotic hyperosmolar hyperglycemia very unlikely. Now, don't let making the diagnosis get you carried away and forget about the precipitating factors of DKA or nonketotic hyperosmolar hyperglycemia. Non-compliance remains probably the most common reason. These patients are typically frequent flyers with recurrent DKA. Infection are probably the second most common triggers, especially in the elderly, particularly pneumonias and UTI. Urine analysis and chest X-ray should be performed in all patients. But beware that severe leukocytosis is a common common finding in DKA and non-ketotic hyperosmolar hyperglycemia even in the absence of infection. So please do not start empiric antibiotic just because of leukocytosis in the absence of any evidence of infection. Acute pancreatitis may precipitate DKA and should be ruled out in patients presenting with abdominal pain. This can be challenging as in DKA, lipase and amylase are often elevated. CT abdomen and pelvis should be performed in these patients to evaluate for acute pancreatitis. Don't forget to order and review an EKG as acute MI is one of the precipitating factors for DKA and non-ketotic hyperosmolar hyperglycemia. Drug screening should be performed if drug use is suspected, particularly in patients with recurrent DKAs as cocaine is known to cause recurrent DKA. Make sure to review home medications and look for any recent use of glucocorticoids. SGLT2 inhibitors should be discontinued indefinitely with DKA, whether with hyperglycemic DKA or normoglycemic DKA. There are some data that suggest an increased risk of diabetes and DKA in patients who were commenced on atypical antipsychotics like clozapine and olanzapine, so look for these medications as well. And remember that any acute sickness can precipitate DKA and non-ketotic hyperosmolar hyperglycemia. Let the patient's history guide your workup. Let's move to the treatment. First of all, the goal of treatment in DKA is to close the anion gap, not to normalize bicarb level. Please remember that well. In addition, to control hyperglycemia. You all know how to calculate the anion gap, sodium minus the addition of the sum of chloride and bicarb. We use the measured sodium here, not the corrected one. The corrected sodium is the measured sodium corrected for hyperglycemia. The measured sodium is the sodium value in the lab results. No need to memorize the correction formula. Just Google it or look it up and just get the results from, just use your phone. On the other hand, the goal of treatment in non-ketotic hyperosmolar hyperglycemia is for patients to become mentally clear and for the effective plasma osmolality to fall below 315 millismol per kg. In non-ketotic hyperosmolar hyperglycemia, it is usually more than 320. And to control, of course, in addition to control hyperglycemia. Now, mentally clear is not always feasible, especially if the patient is intubated on mechanical ventilation or had a catastrophic intracranial event. But what's the effective plasma osmolality? As you know, serum osmolality, it's the double of sodium plus glucose divided by 18 plus BUN divided by 2.8. BUN freely moves between the intra and extracellular spaces and is considered ineffective osmoles. So we are only left with sodium and glucose as effective osmoles. So the effective plasma osmolality is 2 times the sodium and plus glucose divided by 18, as you see in this equation. We use measured sodium, not corrected one, for hyperglycemia here. I want to refer you to my acid-base disorder videos and hyponatremia series I have on the channel. I posted them almost 2-3 years ago, so the quality may not be great, but they will be extremely helpful. The link to those videos provided below. To achieve these targets in DKA and non-ketotic hyperosmolar hyperglycemia, 3 things are needed to be provided to the patients: fluid resuscitations, insulin administrations, and electrolytes monitoring and replacement. Keep in mind that the primary cause of patient mortality during the initial phase of DKA and non-ketotic hyperosmolar hyperglycemia is severe dehydration and imbalanced electrolytes rather than lack of insulin. Hypothetically speaking, if you had to choose between administering intravenous fluids or insulin during this acute phase, opting for insulin alone would be detrimental and could lead to the patient's demise. On the other hand, selecting IV fluid would be a life-saving measure in the acute phase. So it's okay to delay insulin therapy if needed. Of course, remember to stabilize the patient's airways and breathing first. Mostly this already done by the ED staff and it is not the topic of this video here. Fluid resuscitation should be started as soon as possible. Fluids are more important again than insulin in this early acute phase, and patients are typically still in the ED during this early acute phase. And actually, by the time we are notified about these patients, it's already a few hours from the initial presentation to the ED. I have to say that management in the ED for these patients is not always the best. Again, depends on the ED itself and in the ED physician. The first thing I do as soon as I get notified about the patient from the ED staff is to take over the care of these patients even while they are still in the ED. I go find the patient's nurse in the ED and ask them to report any labs or concerns to me, and please let them know how to reach you. And I ask about the most recent blood sugar checks and all the kinds of treatment that have been provided so far, particularly fluids and insulin. Most of these patients need to be admitted to the ICU. Stable patients alternatively can be admitted to step-down unit if hospital policy permits that. Be prepared to manage your patient in the emergency department as ICU may be full and will be a while before a bed becomes available. Please keep them in PO until the transition from insulin drip to other form of insulin, and we'll come back to this soon toward the end of this video. Also, stop all home insulin and non-insulin diabetic medications. Patients who are using insulin pumps should have them switched off as well. Managing a patient in the ED while waiting for a bed is not as smooth as you think and requires us to be on top of everything. Make sure to verbally communicate your plan to the ED nurse and frequently check back to make sure things are done in a timely manner. By the way, I refer you here to a previous video I made on the channel about the proper way to communicate with ED physicians. Link to that video is also provided below. Central venous access, whether peripherally inserted PICC line or centrally inserted IJ or subclavian central lines, is highly recommended, as this will permit easier and quicker IV fluid resuscitation and potassium supplementations. By the time we see these patients, almost all of them have received an initial fluid resuscitation and an insulin bolus, and some are already on the insulin drip. And probably it's been 2 to 4 hours since the last blood sugar check and BMP checked. So I ask for a stat blood sugar check and a stat BMP. Please hold the insulin drip if the potassium on the initial BMP was less than 3.3 and no potassium supplementation was provided. I'll come back to this soon. DKA and nonketotic hyperosmolar hyperglycemia patients have profound volume depletions, estimated to be around 6 liters in DKA and almost 10 liters in nonketotic hyperosmolar hyperglycemia. So be generous with volume resuscitation and replacement. 15 to 20 ml per kg of fluid to be given in the first hour, with a maximum of 50 ml per kg in the first 4 hours are recommended. So a 70 kilo person will get 1 to 1.5 liters in the first hours and up to 3.5 liters in the first 4 hours. If weight is not available for some reason, just guess it. In most cases, giving 3 to 4 liters in the first 4 hours is going to be just around the recommended amount. Be prepared to give more fluid boluses if patient is still hypotensive or if urine output remained low. The fluid bolus that's already received in the ED should be included in the total amount. Let's say I wanted to give a total of 3 liters and the patient has already received 2 liters in the ED, I will give 1 more liter. The fluid used must be in isotonic solutions, preferably normal saline. LR is an acceptable alternative, of course. For more info about IV fluid, I refer you here to my IV fluid course. Link is provided in the description field. Please do not be intimidated by the risk of pulmonary edema in some patients unless the patient is having active pulmonary edema like shortness of breath, hypoxia, and lung crackles. Just give the fluid if none of this exists. Patients with known history of severe cardiomyopathy can still be severely volume depleted, so please don't deprive them of adequate fluid resuscitation. If you are too concerned, slow down the bolus rate to no faster than 1 liter per hour and reassess after each liter. Simply ask about any shortness of breath, listen to their lungs, and look for any increase in their O2 requirements. And if all is good, then it's safe to continue IV fluid resuscitation. The same applies to end-stage renal disease patients on dialysis who are anuric. After the initial resuscitation, which is typically the first 4 hours, we continue the resuscitation at 250 to 500 ml per hour, but the fluid type will be guided now by the corrected sodium level, not the measured one. I personally use 250 to 300 ml per hour in most patients. Change the fluid to half normal saline if the corrected sodium is normal or high, and keep an isotonic solution if the corrected sodium less than 135. In DKA, I typically continue IV fluid at this rate for the next probably 12 hours, and reassess volume status. If the gap has closed and the patient's blood pressure, heart rate, and urine output all good, then IV fluid can be discontinued once the patient is able to eat and the insulin drip is off. Now, there is a subset of DKA patients that may not require the initial fluid resuscitation, as in those with early and mild DKA and those with normoglycemic DKA. These patients can be directly started on IV fluid like around 250 ml per hour with dextrose solution, but again, look at their volume status and hemodynamics. In nonketotic hyperosmolar hyperglycemia, the volume deficit is larger compared to DKA. Fluid resuscitation likely to be continued beyond the first 24 hours, guided by their volume status, corrected sodium level, and the drop in the effective plasma osmolality. Let's move to the potassium issue. Almost all patients with DKA and nonketotic hyperosmolar hyperglycemia have a significant potassium deficit. But despite this total body depletion, the serum potassium concentration is usually normal or elevated at presentation. This is largely due to insulin deficiency and hyperosmolarity, each of which cause potassium movement out of the cells. This tells you how profound the level of potassium depletion is if the initial potassium in these patients is low. So imagine starting an insulin drip on top of this severely depleted potassium. This will lead to profound and dangerous hypokalemia. For that reason, insulin drip should be delayed until potassium is more than 3.3 milliequivalent per liter. If the insulin drip is already hung in the ED and the initial K was less than 3.3 and not corrected, hold the insulin drip. In most hospitals, DKA and nonketotic hyperosmolar hyperglycemia, there is protocol available, and all you need is just pick the protocol. It has everything about potassium and insulin orders. It's peace of mind. But in general, remember this: serum potassium, the range between 3.3 and 5.3, 2 points difference between the range minimum and maximum. Please delay the initiation of insulin drip if serum potassium is less than 3.3. Potassium supplementation should be provided if potassium is still less than 5.3. Some other sources use slightly different ranges and parameters, so just follow the range you like or just follow your hospital protocol. Now, one common pitfall is that when potassium is less than 3.3, we hang the insulin drip at the same time or soon after giving the potassium before waiting for the next serum potassium. In real world settings, the turnaround time for BMP testing, which is the time from blood draw until it has resulted, is at least 2 hours in most hospitals. You are lucky if your facility has a faster turnaround time. Some facilities have what we call iStat or point of care labs analyzers that provide results within 5 minutes, including potassium level. The blood sample can be in these iStats or point of care can be venous or arterial if ABG with lights is ordered. The point of care results may be slightly higher or lower, but in general they are reliable, so use them if you have them readily available for you. Now, it's okay to delay insulin for the first few hours if needed, particularly since most of the time the patient has received at least an initial insulin bolus ordered by the ED physicians or staff. Now, potassium depletion is a daily encountered issue in inpatient settings, and probably most of you were taught not to infuse potassium faster than 10 milliequivalent per hour, so not to induce any cardiac arrhythmias, which means we need 4 hours to infuse 40 milliequivalent, for example. Now, that's kind of true in non-urgent situation in mild or non-urgent hypokalemic cases. In real world settings, most potassium preparations are infused over 2 to 4 hours. Now, the exception to the potassium replacement protocol is profound and potentially dangerous hypokalemia, as in DKA and nonketotic hyperosmolar hyperglycemia, where a quick replacement to safe level is required. Imagine if I have to wait for 4 hours to finish 40 milliequivalent of KCl infusion and then a couple of more hours to wait for the serum potassium results to come back. We may never catch up with the level of hypokalemia in the first 24 hours, and there will be big delay in the initiation of insulin drip. The way we are going to do it in real world settings is like this. If potassium is less than 3.3 or whatever cutoff you use, delay the initiation of insulin drip and give KCl 20 to 40 milliequivalent IV over 1 hour. Yes, you heard it, over 1 hour. Check serum level after each replacement and repeat KCl 20 to 40 milliequivalent over 1 hour until the potassium is above 3.3. Again, if your facility has a protocol for all of this, just follow the protocol. If you are extremely nervous still about giving that potassium that fast over 1 hour, hour, or maybe the nurse will tell you she's very nervous doing it. Check with your pharmacist and follow their advice, or give it over 2 hours if that will work for everyone. Now, if potassium is between 3.3 and 5.3, add KCl 20 milliequivalent to each liter of IV fluid. Make sure the liter is infused no faster than over an hour. If fluid boluses are given at a faster rate, infuse KCl through a separate bag. Hang insulin drip soon after the initiation of KCl in this case, because potassium is above 3.3. Don't wait for the next BMP and potassium result as long as the potassium is above 3.3. Now, if the potassium is above 5.3, initiate insulin drip and do not give any potassium and continue monitoring. At any point, if the serum potassium drops below 3.3, repeat the step. Hold insulin drip and repeat the step we just mentioned earlier. The goal is to keep potassium between 4 and 5 while on insulin drip. Please remember this. All this talk about potassium replacement is valid only in those with adequate urine output. Remember, urine output may be diminished early in the DKA or nonketotic hyperosmolar hyperglycemia, but usually quickly improves with IV fluid resuscitation. Adequate urine output is at a minimum of 0.5 ml per kg per hour. So in 70 kilo patients, we are looking at a minimum of 35 ml per hour. Potassium replacement should be done at a much slower rate in patients who are on dialysis or those with acute kidney injury who are oliguric or anuric. Remember that 90% of potassium regulation is done through the kidney. In such cases, nephrology consultation is needed, and let them guide you through that. In general, we replace potassium in these patients with a smaller amount at a slower rate. For example, we may give 20 milliequivalent of KCl over 2 hours instead of giving 40 milliequivalent of KCl over 1 hour. But again, consult with nephrology if available. In my previous video about insulin drip, I mentioned the following. Now, I take that back. Although I've done it before, but it requires a lot of close monitoring and effort to stay on top of it. It's much better practice to delay insulin drip until potassium is above 3.3, so please accept my apology for this. Now, how about phosphorus, PO4? Similar to potassium, phosphorus is typically depleted in these patients despite the initial normal or elevated serum PO4. The difference here is that hypophosphatemia is not as dangerous as hypokalemia, and the body can tolerate that well. Unless there is severe hypophosphatemia, serum phosphorus concentration below 1 mg per deciliter. Replacement otherwise is not required. So if the initial phosphorus was 2 or more, we don't need even to do serial phosphorus level, and maybe we just repeat it with next morning labs. But if it's less than 1, then we have to replace and repeat it. Severe metabolic acidosis with pH less than 7 may occur in DKA, but fortunately it improves quickly with IV fluid and insulin therapy. Most of these patients, despite extremely low pH less than 7, are still awake and alert with stable cardiac rhythm and function, unlike other causes of severe metabolic acidosis. That's why I rarely use sodium bicarb pushes or drips in DKA in clinical practice. Some now recommend giving sodium bicarb if the pH is equal or less than 6.9, and only to bring it to pH of 7, not just to keep it going. On the other hand, bicarb drip should be, or bicarb pushes should be promptly given if any signs of cardiac instability like hypotension and EKG changes. Review the EKGs and keep an eye on the cardiac monitor for these patients, and if at any point you see the QRS is broadening or widening, act quickly. Your patient is on the verge of cardiac arrest secondary to severe acidosis and hyperkalemia. Push bicarb and calcium immediately. And to be honest with you, I've never seen it in DKA patients, but I have observed it more frequently in cases of severe lactic acidosis caused by hypoperfusion, such as in septic shocks. Now, sodium bicarb can be given as pushes or as a drip. Hospitals usually have pre-filled 50 cc ampoules or syringes of sodium bicarb. Each ampoule has 100 ml equivalent of sodium bicarb, 50 of sodium and 50 of bicarb. In life-threatening situations, pushing 1 to 2 ampoules should be done before starting the drip. Push calcium as well, please, as life-threatening acidosis is typically associated with critical hyperkalemia. The proper way to order sodium bicarb drip is by mixing 3 amps of sodium bicarb in 1000 cc of free water or 1.5 amp in 1000 cc of half normal saline. Avoid mixing in D5W. We do not want to give these patients more glucose. Let's move to insulin therapy. Now our patient potassium is above 3.3. Most if not all have received the initial bolus of insulin of 0.1 per kg already in the ED, and it's time to initiate the insulin drip. Again, simply follow your facility DKA or non-ketotic hyperosmolar hyperglycemia insulin drip protocol. If the initial bolus has not been given yet, it should be given if blood sugar is above 250. Please ask for a stat blood sugar check. Don't rely on previous blood sugar check before giving this insulin bolus. This initial bolus is not needed in normal glycemic DKA patients, as these patients should be directly started on the drip. The initial drip rate is similar to the bolus amount, 0.1 per kg per hour. So 100 kilo patients will receive 10 units of IV insulin and then start on the drip at 10 units per hour. Some may skip the initial bolus but start the drip at a higher rate of 0.14 per kg per hour. Our 100 kilo patients will be started at 14 units per hour without an initial bolus if we decide to use this approach. Now, all this time we have been saying regular insulin is the only insulin that's available in IV form. Well, this is not true, but human regular insulin is the cheapest and probably the only IV insulin that's available in most if not all hospitals in the USA. Insulin glulisine or Apidra is an insulin analog that comes in IV form as well, but it's way more expensive and not superior to IV human regular insulin, so I'm not sure if you will ever need to use it. Please check blood sugar every hour in the initial acute phase. Once the blood sugar is stable with a desired drop in the blood sugar checks can be switched to every 2 hours, or you could keep it every hour. It is not a big deal here. While on insulin drip, please check BMP every 2 to 4 hours. Practically every 4 hours is easier, especially when the turnaround time is 2 to 4 hours, except when the potassium drops less than 3.3. In such a case, hold insulin drip, replete potassium, and order BMP every 2 hours, as we explained earlier. There is no need to do serial ABGs for pH monitoring unless bicarb is being used to raise the pH. VBG or venous blood gas can be a good alternative as it's easier to obtain than arterial blood gas and provide a good estimate of the arterial pH. In the description field as well, you will find a link to my VBG versus ABG video. After initiating the drip, our aim is to reduce blood sugar levels by 50 to 100 within the first hour. If this desired drop is not achieved, we recommend doubling the drip rate. When the serum glucose approaches 250 mg per deciliter in both DKA and non-ketotic hyperosmolar hyperglycemia, add dextrose solution to the IV fluid being given already and attempt to decrease the insulin infusion rate to 0.02 to 0.05 units per kg per hour. Of course, some may advise to switch at blood sugar of 200 or 300. It doesn't really matter. The goal of this switch is to prevent hypoglycemia while awaiting for anion gap to close in DKA and to avoid a quick drop in effective serum osmolality, which may promote cerebral edema in non-ketotic hyperosmolar hyperglycemia. If possible, do not allow the serum glucose at this time to fall below 200 mg per deciliter in DKA or 250 to 300 mg per deciliter in non-ketotic hyperosmolar hyperglycemia, because this may promote the development of cerebral edema. Now, early and mild DKA can be alternatively managed with sub-Q rapid-acting insulin analogs. Early and mild DKA patients usually have a mild anion gap. In my facility labs, usually their anion gap less than 15 and the bicarb level is usually above 15. These patients are hemodynamically stable and most of them present early to the ED with an acute sickness that caused them to have decreased oral intake. They stopped taking their medication, diabetes medication, because they were afraid of hypoglycemia. Now, these patients should receive fluid resuscitation and can be treated with insulin drip, but alternatively, rapid-acting insulin can be used. In such a case, we administer 0.3 per kg units sub-Q, followed by 0.2 per kg 1 hour after that, then 0.2 per kg every 2 hours until the blood sugar is around 250. Then we reduce it to 0.1 per kg every 2 hours until the gap is closed. BMP monitoring and changing the fluid is similar to what we explained earlier. So when they drop to 250, make sure to add dextrose solution to their fluid. Let's move to the transition. Transition in DKA starts when the anion gap is closed. One common pitfall is that some switch the insulin drip off or feed the patient before the anion gap is closed because of low blood sugar and the risk of hypoglycemia. Please do not switch off the insulin drip before anion gap is closed in DKA. If hypoglycemia develops, correct it with a dextrose solution and lower the drip to 1 unit per hour until the gap is closed. In non-ketotic hyperosmolar hyperglycemia, we continue insulin drip until the following are achieved. The glucose level is 250 to 300 mg per deciliter. The effective plasma or serum osmolality is less than 315 millismol per kg, and the patient becomes more alert. In both DKA and non-ketotic hyperosmolar hyperglycemia, I delay the transition and keep them on insulin drip until they are able to eat or a source of nutrition is provided, like tube feed or TPN. So how do we do the transition? It's kind of similar to the way we explained in the insulin drip video. First, calculate the total amount of human regular insulin received in the last 24 hours. If we cannot find the exact amount, a rough estimate can be used by finding the last 2 or 4 readings, summing them up and multiplying them by 12 if 2 readings or 6 if 4 readings. The next step is the 2/3, 1/3 rule, which you all probably know. We divide the total amount received in the last 24 hours by 3, 2/3 of which will be given as basal insulin and 1/3 as scheduled pre-meal rapid acting insulin. Of course, this is if the patient is expected to have adequate oral intake. If the patient is NPO or oral intake is poor or unreliable, we only give the basal insulin after making these calculations. Now, after making this calculation, we give the first dose of basal insulin now in order to switch the insulin drip 2 hours after giving the first dose of basal insulin. Once the insulin drip is switch off any IV dextrose solution, start a diabetic diet, switch blood sugar to ACHS before meals and at bedtime, stop serial BMP, start the scheduled pre-meal insulin, and add a correction sliding scale. Some may want to continue blood sugar checks every 2 hours times 3 and 1 more BMP in some selected patients whom we feel are at risk of bouncing back into DKA. Now, you may read or find about other ways of transition, but this is the way I've been using for years and it's been working well without any problem. For patients with non-diabetes who were previously being treated with insulin, their pre-DKA or non-ketotic hyperosmolar hyperglycemia insulin regimens may be restarted. We give their home basal insulin amount now and then follow the steps mentioned above. If we feel their home insulin regimen was not enough, we can follow the 2/3, 1/3 rule we just mentioned. For patients on insulin pumps, we start the previous pump basal rate, then switch the insulin drip off 2 hours later. However, if the IV insulin requirement are significantly higher than their usual insulin requirement, it's reasonable to increase the basal rate temporarily. For patients who were treated with non-insulin medications, it's better to delay their transition back to non-insulin medication as an outpatient, do it as an outpatient or before their discharge when they are completely stable. At the end, thanks for sticking around to the end. If you found this video useful, give us thumbs up and share it with your colleagues, please. Thanks for watching and see you soon.